Welcome everyone. This is SM Abdullah, a member of Health Economics Research Network and a PhD researcher at the Department of Health Sciences in University of York. Thank you for joining us despite your busy schedule. This webinar is part of our ongoing capacity building efforts in collaboration with Center of Health Economics, University of York. Today, we are honored to have Dr. Jahangir Khan, Professor of Health Economics at the University of Gothenburg, Sweden, and Dr. Sayem Ahmed, a health economist from Brunel University, London, UK, as our distinguished speakers. This webinar will address the status of universal health coverage in Bangladesh, highlighting both challenges and opportunities. Universal health coverage ensures that everyone has access to necessary health services at a reasonable cost and adequate quality. Achieving this target requires efficient and equitable healthcare, revenue collection, and digitization. Professor Khan's research focuses on universal health coverage status and progress across various countries, utilizing health economics theories and empirical investigations. His work covers healthcare financing, health insurance, catastrophic expenditures, and the impact of sickness, disability, and death on poverty. He is particularly interested in developing research students' skills in analyzing universal health coverage in countries with diverse economic background. Ahmed, on the other hand, is the director of the MSc in Health Economics and Health Policy program in the Division of Global Public Health in the Brunel University, London. His research focuses on health economics, particularly health technology assessment, economic evaluation, and healthcare financing, with significant contributions to evidence-based resource allocation and decision-making in healthcare worldwide. Accordingly, I believe the forthcoming hour will be enlightening for aspiring health economics researchers and academicians. So without taking much of time, I'm interested to hear from both of them. Considering the time limitation, the housekeeping rule for our participants would be the chat box will remain always open and you can always post questions here. We would like to request our participants to keep their microphone muted for smooth progress. So with these words, I would like to welcome Dr. Khan and Dr. Ahmed today. Sir, it's over to you. Thank you.
Welcome everybody to the presentation about universal health coverage status in Bangladesh. We shall be talking about some challenges and opportunities. I shall start with a brief presentation of what is universal health coverage and then continue with our own research as well as research from some other researchers. We all are familiar with this 17 goals of 17 sustainable development goals, and universal health coverage is connected to or strongly connected to good health and well-being. But you can find that some other goals are connected with universal health coverage aspect. Like poverty can be one issue, gender equality and so forth. But anyways, we focus on this, and the indicator 3.8 or two indicators in 3.8 is about universal health coverage. So there are two indicators here. The first one in 3.8 coverage of essential health services, which we need to ensure for achieving universal health coverage, and we should nullify the catastrophic health spending on health. That is, if somebody pay for healthcare should not face catastrophic economic consequence or even poverty. So those two indicators we have in our mind when we shall be presenting universal health coverage status in Bangladesh today. And this is a box which illustrates the universal health coverage aspect. As Abdullah already said, we have to cover all types of health services like promotive, preventive, curative, rehabilitative, and palliative services with sufficient quality. And for accessing those services, nobody should face financial hardship. And this box, the transparent box, illustrates the entire universal health coverage situation with three dimensions. This is the population dimension you see here. Population dimension here. So if we can cover entirely here, then we would achieve universal health coverage. But the blue box is showing a specific country, the status of a specific country. So we see that this part is uncovered And this uncovered can be, for instance, people in the hard to reach area may not be covered, or people in the slum area may not be covered by health services. So all the population may not be covered in some countries. So we have to extend this population coverage. In this dimension, you have service coverage. So all the essential services should be covered. And sometimes you remember that during the pandemic, COVID services were not covered in all the countries of the world. But any kind of services should be, or essential services should be covered. And the cost sharing should be, if you reach the ceiling here, then you are covered for, you make it affordable for everybody. By using the pooled fund like health insurance or tax-based health services and so forth. Okay, so this blue box we intend to bring to the transparent large box, and you have to ensure the quality of services as well. So Margaret Chen, director of WHO, in 2012 said that what good does it do to offer free maternal care and have a high proportion of babies delivered in health facilities if the quality of care is substandard or even dangerous. So we should keep in mind that health services should not be dangerous. Rather, we must have a very standard quality of service we should keep. And your quality of service can be realized on health service centers level. It should be safe, it should be effective, people-centered and timely. And the quality should be realized even in health system level, like it should be equitable, it should be integrated and efficient. So those components of quality we should keep in our health system. I will give some focus on the global level, how according to the latest global monitoring report of universal health coverage, some important points probably we should keep in mind, because the world faced a pandemic and some other economic consequences globally. So you see here, COVID outbreak actually had a very negative consequence on the progress of universal health coverage globally, and particularly low and middle income countries. We have seen that they have reallocated resources for pandemic management. So universal health coverage targeted resources might probably in many countries could not be utilized as it was planned before pandemic. And we have seen that Ukraine war and COVID-19 together had a very strong economic consequence in many countries. It was downturn of the economy. We have observed inflations, and many people fell into poverty due to those two consequences and two reasons, that is Ukraine war and COVID. We have also observed in data 2021 that 4.5 million people are not covered by essential health services. And of course, we have to say that even the COVID services were, of course, it was an essential service, and most of the countries could not cover it, particularly in the beginning of pandemic. 2 billion people were in economic hardship, and 340 million was in extreme poverty. So there was a big challenge globally in the context of economy. And we have seen that some countries, like 1/3 of the countries globally, made progress towards universal health coverage in terms of better access to healthcare. But however, we have seen many countries, 96 out of 130 where we have the data, went to wrong direction regarding access to healthcare. So, you are not covering the services, rather you see that you have a lot of uncovered services in health services. So it was in the health system in many countries. So those are the challenges we have seen globally. I want to give some idea about how out-of-pocket payment can be a problem for achieving universal health coverage. So here I have taken the OECD countries. Those are generally the rich countries in the world, or high-income countries. So then if we just take that 20% is acceptable as a out-of-pocket payments, it's my own gaze, not academic one. But if we accept 20% out-of-pocket payment in any countries, we have seen the most of the OECD countries are having less than 20% out-of-pocket payment. Some countries have higher. We've seen Mexico has close, 38% and so forth. That is the highest among the OECD countries. But the most of the countries are having lower out-of-pocket payment. On the other hand, I have selected some low and middle income countries randomly, and I put this 20% here, and I feel that many countries actually have more than 20% out-of-pocket payments. And Afghanistan had kind of 75%, Nigeria peaked to 73-4%, Bangladesh 74%, and so forth. So pretty high out-of-pocket payments in Bangladesh compared to many low and middle income countries. Yeah, it might maybe like this. Like some countries have low out-of-pocket payment, like Rwanda, and it might be explained by the international support as well, and many other countries are international support as well. So lower out-of-pocket payments doesn't always mean that the country has a sustainable healthcare financing system. It might be dependent on international development partners in some countries. Many of them, but many countries like Cuba has their own resources and so forth. So, but we see that countries are are having high out-of-pocket payments for accessing health services. So what can be the consequence of out-of-pocket payments? If you rely on out-of-pocket payments, one problem is that it is a barrier against healthcare utilization, particularly for the poor community in a society or low-income people in a society. And even if many households can access healthcare by spending money, many of them face catastrophic health spending, and a number of them or a part of them fall into poverty because of payment for healthcare. So it is a barrier for low-income people, and if people can pay, they can face catastrophic health expenditure, even can fall into poverty because of out-of-pocket payments. So those are affecting actually the universal health coverage indicator very negatively. Now Sayem will be talking about some experience we had from Bangladesh. Please, Sayem.
Thank you, Professor Jahangir, for passing it to me. So in this section of the presentation, I will present some empirical research from Bangladesh. Some of them we conducted, and also other health economic research are conducted in Bangladesh context. So this empirical evidence will be useful to understand the challenges of the universal health coverage from the economic perspective. So here is two screenshot of our article where we publish the evidence on the catastrophic health expenditure from two nationwide survey, household income expenditure survey conducted by Bangladesh Bureau of Statistics. So I will share some numbers from these studies. Next slide, please. So this is from the household income expenditure survey 2010, and we estimated that around 14% household face catastrophic health expenditure, and we defined here catastrophic health expenditure if any household that spend more than 10% of their total household consumption expenditure in health, then they are facing the catastrophic health expenditure. And considering this definition in 2010, 14.2% household face catastrophic health expenditure. And also this in the later year, in 2016, we got around 24%. So there is a huge increase in the catastrophic health expenditure between these 2 years, two analysis we did in different time points. So we can see the from the national health accounts as well in the Bangladesh that the share of out-of-pocket payment also increasing over the time period. But here we are presenting the incidence of the catastrophic health expenditure in this figure by the asset quintiles or the economic status of the household. So in the total sample, we can see that considering the both definition, one is considering the 10% of the total household consumption expenditure, and another is 40% of the non-food expenditure. That is also sometime researchers suggested considering, because non-food expenditure represent better the capacity to pay of the household. That's why we use that definition also here. So what we can see from this graph, that there is a catastrophic health expenditure, that is the incidence is higher in the poor group of the population. It is also in the urban and also rural sample. We can see the poor, they are affected more by the catastrophic health expenditure. So we can see the poor people, they are suffering more because of the dependence of the out-of-pocket payment condition, or dependence of the out-of-pocket payments of our healthcare financing system. So that is affecting the poor group of the population. Ideally, the poor should be covered, and they should not be affected hugely by the out-of-pocket payment. So we can see here that one of the challenges that in our context, the out-of-pocket, the catastrophic health expenditure, that is very high, and also the poor group of the population, they are facing huge challenges because of this out-of-pocket payment in our health system. So in this is the Penn's parade graph we call. I will explain the impoverishment impact of the out-of-pocket payments. So how the health expenditure that can be one of the reason of falling below the poverty line. So I will explain that. Although the figure looks very clumsy, but if I explain, maybe it will be easier. So in the vertical axis, I presented the household consumption expenditure as multiple of the poverty line. So we can see the poverty line at the 1. So that is our poverty line. And also some people have very high expenditure. For example, they have two times of their of the poverty line, or 4 times. So we have very high spending household, and also very low spending household as well under the poverty line. So we can see all the households, individuals here in our data set. So we can see the around that time the poverty was around 30%. So that's why we can see this group of the population below poverty line, because this is based on the 2010 data set. So what we can see, there are some droplets, and that indicates the difference when we deduct the out-of-pocket payment from the total consumption expenditure. So this household position changes from the current position to below, where they drop after deducting the out-of-pocket payment, because they spend that money for the health spending. So if we deduct that, we can see some of the household who are above the poverty line, they are falling below the poverty line. So if we reduce the or deduct the out-of-pocket payment, so we can see many household in this above poverty group, they are falling below poverty line because of the health expenditure or out-of-pocket payment. And if we estimate the average, it is 3.5% of the above poverty line population, they fall below poverty line because of the out-of-pocket payment. And also, if we see the other part of the sample, that is the below poverty line population, we can see if we deduct the out-of-pocket payment, their poverty condition also deteriorated. So they have worse condition in terms of their poverty situation after deducting the out-of-pocket payment. So it is from this figure, we can see that the above poverty line population, they fell below poverty line because of the out-of-pocket payment, and also it is affecting the below poverty line population. Their effect also deteriorated. And we need to keep in mind that household income expenditure survey, that is a cross-sectional survey. So we don't have any follow-up data from here. So we don't know if this household, they recover from poverty quickly after the health episode or treatment episode completed. So we don't know that. Only in that time point, we can see that 3.5% of the total population, they are falling below poverty line because of the out-of-pocket payment. So this is one of the challenges also, a huge economic impact, because one of the our target is to reduce the poverty in the country, but this health system of our country or dependence on the out-of-pocket payment, that also increase that problem, that many people, they are falling below poverty line because of this. And this is the similar figure from the 2016. So we can see that the intensity of the out-of-pocket payment, that is increasing over the year. And also we can see here that around 4.5% of the total above poverty line population, they fell below poverty because of this out-of-pocket payment in this year. And also we can see the updated catastrophic health expenditure estimate, that is 24%. So it was around 14% in the 2010. So it is increasing day by day in our context. And also if we see the national health accounts, that around 2007, the estimate was 64% of the total health expenditure spent as out-of-pocket payment, but it increased now up to 74%, as Professor Jahangir also shown in the slide already. So it is the out-pocket payment also increasing. So it impacts on the catastrophic health expenditure, and poverty also increasing in our context. So the recent estimate that BIDS conducted a study based on the 2022 household income expenditure survey, and they observed around 3.7% impoverishment impact from their estimation. And this is one of the largest scale intervention or in the pilot state now, although it is planned by the Health Economics Unit, and they are implementing in different upazila settings. So that is called the Shastro Surakha Karmoshuchi, that is designed for covering the poor people and by the government fund, and delivering them health services through public and private network, and also covering through the public fund as a health protection scheme. So one of the ICD-DRB research study that conducted a impact assessment of this pilot scheme currently ongoing in the Gazipur and other district around the similar area. So they only estimated the household utilizing the SSK benefits, and they found that some of this out of impact of the out-of-pocket payment that I explained in my earlier slide, that can be reduced by the SSK program. If I explain this figure, that is, we can see the impact on the catastrophic health expenditure here. So the red line that show the comparison group, and also the green line that show the SSK, any people who are covered by the SSK. So we can see that considering all the threshold level, catastrophic health expenditure threshold level, the household have lower incidence of the catastrophic health expenditure in the SSK group. So SSK that is helping to reduce the out-of-pocket payment around 92% if the member utilize the service. So they did not include a huge chunk of member who did not use any service. So it is only within the member who use the service, because we know there are some implementation issues of the program. So many member don't know well about the program, so that part was not considered in this assessment. And also catastrophic health expenditure incidence also reduced by 72%, and also impoverishment that reduced by 27%, who utilize the service from the SSK program. So in the next slide, Professor Jahangir will explain the inequality challenges of the universal health coverage.
Yeah, we did another study and on how health benefits are distributed across socioeconomic groups when people are taking services from public sector, private sector, and NGO hospitals and health facilities. So we have found that though people who are accessing health services or utilizing health services from public sectors are pretty equitable across socioeconomic groups. The left one is the poorest socioeconomic group, and the right one is the richest. Uh, and we see it is pretty similar. When people are purchasing, and when we talk about health benefits, that is the services they are taking, how much those services cost. That is the benefit of the people accessing through health system. And if we see the private sector, we see the poorest people are having lower health benefit, and richest people are having highest benefit from the health system. And it is pretty clear socioeconomic gradient we can see here. In the NGO sector, I mean, we don't see any pattern. It is different for different groups. But finally, when we sum up all of them, the NGO sector is small, private sector is huge, in terms of benefit, public sector a large number, but still may not be a lot of like in private sector. So the final one, if we sum up all three of them, then we find this graph, and we see that the poorest has lowest benefit and richest has the highest benefit, and is highly skewed towards richer people in the society, the benefits. And when we calculated the concentration index, we have found that it is highly skewed to the richer people, and the inequality, 96% of the inequality is explained by the private sector inequality. So the use of private sector in Bangladesh is creating a lot of inequality in the society while we are accessing health services. So this one is a big challenge, that how to handle this private sector so that they can contribute to the equitable health system instead of making so large inequality in the society. Okay, so we have strong recommendation about it. We talk it about the recommendation later. So you see that what Sayem has presented, catastrophic health expenditure, we calculated in 2010 and 2016, and I have observed a bit, some research on poverty impact in 2022 by Abdul Razak Sarkar of BIDS. We did not see the whole publication, but got some figures. And very interestingly, the healthcare financing strategy of Bangladesh was established in 2012. And after 2012, it is all the time out-of-pocket payment is increasing. But we are expecting that by 2030, it would be 50%. That is, in 2012 it was around, or 2010 it was around 64% out-of-pocket payments, which should be 32%. But we are seeing instead it is increasing. And of course, private sector has a very high influence on increasing out-of-pocket payments. When we have seen these challenges, we have created also one universal health coverage index we have developed, and it's a pretty simple index using the data from World Bank. We have tested that one as well, and we had in our mind the illustration of universal health coverage, that is the large transparent box, and the blue box which is showing the actual country, and what percentage of this blue box has covered the transparent box. That percentage we have captured from the data. You remember that in the beginning I have shown one figure. So what we found that Nepal, we had data from 6 Asian countries, and we took the information about some essential services like ANC, even also hospitalization services, and so immunization also was there. So there are Some indicators, health indicators or healthcare indicators we used from World Bank data, and we found that 26% achievement of universal health coverage in Nepal, 32% in Bangladesh, and we have observed that Kazakhstan has highest among 6 Asian countries. It is 59%. We had also some African countries, and we found that Chad has a very low achievement of universal health coverage, around 9%, but Namibia has 55.3% universal health coverage index. So first we have described the challenges. Now they are how we can monitor the universal health coverage status in different countries, and this is one indicator, UHC indicator, which can be used for understanding that how we are progressing towards universal health coverage. We see that some countries are facing challenges, but we have seen that in different countries we have been very successful for achieving universal health coverage. They have used national health insurance, like in UK, Sweden, Norway, and so forth. And Bangladesh, we have the government health facilities. Those are also kind of national health. Those are actually the national health insurance for people in Bangladesh. So we have existence of national health insurance in Bangladesh, even if we don't feel a lot about. Feel in that sense, people are not aware of it, these terminologies. So national health insurance is one way recommended. Another is social health insurance, like in Germany and Belgium, some dedicated health insurance package they have. Community-based health insurance for the developing nations can be one solution for achieving universal health coverage. Of course, you cannot stay in community-based health insurance all the time. That can be a good starting point, and then you may need to move towards social health insurance and national health insurance and so forth. Private health insurance in USA is another solution, but we are aware that even if USA has a very low out-of-pocket payments, around 10%, less than European countries and many successful health systems, but USA has very high health expenditure per capita. Like when Sweden has around $6,000, USA more than $10,000. So this is another problem. But in terms of out-of-pocket payments, private health insurance is one solution also, but it may not be the best solution. We have seen that national health insurance and social health insurance had very good success globally. And here I am comparing the countries in 2005 and 2019, how Bangladesh, the resources in Bangladesh were distributed in pooled fund, like if I take this national health insurance type, and comparing also that what is out-of-pocket payments there. So we find that in 2005, 65% was out-of-pocket payments and 22.2% was the pooled fund through government taxation and so forth. Some other private 3.4%, and the external funding from development partners 9.6%. But if we compare the red and green one, we see that it increased in Bangladesh between 2005 and 2019. But in Kenya, we see that it was 45% in 2005 out-of-pocket payments, which reduced to 24.3%. And on the other hand, the pooled fund increased from 28 to 46%. In Ghana, it is pretty similar over the years. The distribution, government expenditure and out-of-pocket payment. In Philippines, we have seen the pooled fund, the government expenditure increased from 33 to 40%. In Colombia, it is pretty similar over the years. And in Thailand, it increased, that is the government expenditure increased. So you see that pooled fund in Bangladesh is very poor and it is reducing. On the other hand, the countries were making good progress towards universal health coverage. They have a higher expenditure on higher expenditure from the government. So those are the things we need to keep in mind. We have to make our pool fund larger. It can be by government, it can be by insurance pools and so forth, but it is very important that we work for pool fund. That is insurance. And yeah, we have tested one community-based health insurance in Bangladesh. It was located in Chatpur. And Sam, do you like to say that?
Yeah. So around 2014, we conducted this study of a impact assessment of a community-based health insurance, and we assessed the impact on the utilization of health services and also out-of-pocket payment. And we adopted a quasi-experimental study design. So we had two groups, one with the insured member, and also we compare with the non-insured masked member in this study. And what we find, we presented in this regression model result, that is the healthcare utilization in the base model, it increased 1.75 times compared to the control group. So we can see insurance that can increase the utilization of the health services. And when we adjusted, this is 2.1 times higher utilization of the health services among the member of the health insurance, community-based health insurance scheme. And in terms of the out-of-pocket payment reduction, we found that 6.4% reduction in the out-of-pocket payment because of this community-based health insurance scheme.
Yeah, thank you, Sam. So we have we had some observation that the community-based health insurance probably can be a good point for generating new resources for health, because allocation by the government sometimes takes long time for making decision and so forth. By that time, community-based health insurance probably can influence in two ways. One is generating new resources. At the same time, people will be aware about prepayment schemes, that if I pay something, then I will get my health services free or at lower cost. So that kind of understanding will be more, people will be more habituated with this kind of system. We have some recommendation based on mostly from our research, and not only that, we have some other observations as well. So one thing, you remember that health benefit highly skewed towards richer quintiles of the society, richer people of the society, what we have said in the private sector. But in the public sector, it is equitable, what we have observed. So we want to recommend that purchase care from private sector using public fund. So if the government contract the private clinics and hospital for providing services to the people, then people will be able to access health services with lower out-of-pocket payments. This is one way we can utilize our private sector for creating equity. And I have seen that in Sweden, for instance, many of you probably, or some of you may say that Sweden is a developed high-income country, it is a different nature. But it's not the point. Actually, we are using many tools from high-income countries for developing the low and middle income countries' systems and so forth. So in that case, in Sweden, we have seen that the pool fund, that is the tax fund, is connected to the private hospitals as well. So private hospitals are providing services to the people, to the patients. Patients are paying small out-of-pocket payments like user charge. Rest of the money is coming from the government fund to the private hospitals. So we need to develop this kind of things, and in that case, transparency, accountability, all those things need to be secured. We need to develop a system there as well. In that way, we can get equity in healthcare utilization. Yeah, this is one recommendation we can make. Another one is generating new resources and securing lower out-of-pocket payment. We have tested a community-based health insurance. If we have a large number of community-based health insurance in the entire country, supported by the government, some technical team centrally, then probably we will be able to, this discussion that we can have for a long time, but it is a limited time I have. So we can generate new resources, we can make the behavior of the people towards health insurance by this community-based health insurance. And with the recent change in the country, in Bangladesh, when the last government fall, we have seen that many of our patients used to go to India for health services. But I think that, and now we got some restrictions because of visa issues and so forth. So we can develop our own health system better, quality health services we can ensure, so that we can restrict restrict, not regulated, but we can attract people to stay in Bangladesh and take services from Bangladesh instead of going abroad. So we need to improve the quality of care in Bangladesh and keep our patients home, so that we have our resources home. We can suggest the government to allocate more resources, but that should be utilized efficiently and equitably. And we also think about the political commitment we should increase. I think we don't have enough public movement for improving the health system. We have some dedicated, but we don't have very large impact on that. So how to bring the politician into the discussion, it may help a lot. This is our recommendations, limited. We have some other recommendations in mind, but we keep within those right now. And I want to address some of the issues what the United Nations talk about for working towards universal health coverage. Some action points like political leadership. That one we need to secure also. That one we have recommended as well. Leave no one behind. So we need to bring all the socioeconomic groups, everybody, rich people, poor people, hard to reach area people, urban, rural people, and so forth. All of them we bring together. So when we are planning universal health coverage, we need to think about every single component of the society. We need to have good or appropriate laws and regulations for addressing universal health coverage. For instance, for developing community-based health insurance, do we have good laws and regulations for that, or it is restricted by the regulations? So we need to work for that as well, and it is just one example. So we need to strengthen the workforce for health services so that they can provide quality health services. There's another strong area we need to work with. It's very interestingly in Bangladesh, the doctors-nurse ratio is just reverse to the a good health system. Like in Bangladesh, we have more doctors, less nurses. On the other hand, we see that in the good health system, there's a more nurses, lower number of doctors. So this combination and distribution of task should be appropriately addressed in a health system. We need to invest more money, but in a better way, in a smarter investment we need to make, so that kind of it should be cost effective, the services should be efficient, and so forth. We need to move together, both the government and the development partners, all the stakeholders. We should move together towards universal health coverage. We need to guarantee gender equality in health, so that we need to say that even men, women, transgender, and so forth, we need to address all of them and their health services equitably. And we need to connect universal health coverage and health security in the health system. And you can have more information about the agenda of United Nations. So that's what we had for today to discuss. And I'll be happy if you have any questions which we can address.
Thank you, sir. Thank you, Professor Khan and Dr. Ahmed, for enlightening us with such an informative presentation. And it's good to know that this amount of work is taking place in Bangladesh, focusing universal health coverage, which is, I guess, one of the most priority area if we want to, if we want to ensure the equity in health and provide the service towards the door of rural and hard to reach people. So I have two questions that I have received during your presentation from the chat box from Mr. Aminul Islam. And I will just read out the questions for your convenience, and any one of you can address those. So the first question was, what are the most significant barriers to achieving universal health coverage in Bangladesh, particularly in terms of healthcare financing and equitable access for rural and marginalized population? So that was the first question.
Yeah, thank you. Thanks, Mr. Aminul. One problem is that whenever we are spending for health, we are not thinking about the pooled fund. That is, the fund like through health insurance or the tax fund and so forth. So when we are spending the money, our system is like that. I have to pay from my own pocket for getting my health services, and in that case it is creating a lot of inequity. If you are richer, you are spending more. If you are poorer, you are spending less. And even it is difficult for you to access healthcare. So one thing is, it should be an integrated system where we have the opportunity to create pool fund for accessing health services. So this is one thing. Another thing is, we don't have sufficient budget for health, and it's pretty much not need based budgeting. We see that the budget is increasing slightly every year. So we need to make it very clear that our budget should address the need for healthcare. So this kind of decision making is very important. Another
Yeah,
thing,
so
our behavior of the people. We are not pretty familiar to put money on health before we get sick. That is, again, we talk about the health insurance issues. So we need to change the behavior of the people, how to collect money for healthcare, and how to utilize those money for health services. Another thing, what you see in our research, that the health benefit is skewed towards richer people of the society. If we use our private sector how we are using today, that we will be going towards more and more inequity in the society, more and more challenges. Many people will be left, especially the marginal people, what you talked about, and the poorer people in the society. They will have difficulties for that. We need to create pool fund. SSK is a good example. That Shastro Shurakha Karmashuchi. That is a very good example. But we need to utilize this in the right way, and we need to make it robustly. We need to develop this scheme for the marginalized people in the society. So those are some examples we can talk.
yeah. Uh, Thank you, sir. There is another question from Mr. Aminul, and that says, what measures can be taken to reduce catastrophic health expenditures in Bangladesh, especially for low-income households and those in rural areas? Is it option of national health account? What do you think?
Yeah, I think again that the program like SSK is one opportunity again. That is, the government is paying the premium for the poorest people in the society or marginalized people in the society, and they will have access to health services. So the government, from the tax money, they should take care of the poorer people in the society. On the other hand, those who are they can afford healthcare, that is a bit above the poorer condition, above the poor or non-poor people, according to their ability, they should pay to the health system as a prepayment. That one can be a good solution. And even if we find that it is a big challenge for creating the pool fund or prepayment scheme, but I think we should take this challenge, because those countries uh, who could develop this kind of system actually have been very successful in healthcare financing and reducing catastrophic health expenditure or poverty impact. Sam, if you have
Uh,
anything to say, please add.
Yeah, sir, thank you. From Mr. Azdi, I have got a question to you, and it says, why do you think our government, like ours, are reluctant to increase healthcare funds, and why can't they connect this investment to the economic development of the country? What's your opinion?
Yeah, there are different reasons actually. One thing is, government sometimes says that the money what is allocated for health is not spent even in. Sometimes it comes back to the ministry. Um, and there are actually a lot of different regulations we have when we are spending money, or the hospitals are spending money, or So because of this kind of restrictions, uh, sometimes all the money are not spent. So this is one thing often used as a argument for not increasing the fund. But I think the regulation for um, spending the money should be relaxed, so that you can use the money according to the need for the hospitals or the clinics, or the health facilities there. So this is one thing. And I think health is the most essential part of the people, but the poorest political commitment we could create from the people. Because you see that when we discuss about some other political issues like power game and others, the people are very interested. When we talk about health, people are not very much interested. So we need to create the interest among the people that health is a very important sector, where we need to so that we can make the politician more interested in this area. If I am not interested in health, why should my MP interested in that one? So we need to engage the people, and of course we need to make a very strong connection between the health movement, and the researchers, so that you
Yeah.
talk about you talk with evidence. You don't talk just I want this thing and that thing. It's not like that. Evidence based, um, evidence based approach for the movement, health movement, so that we can make more politicians interested in this area. And we have seen that the leadership in health is very poor. We don't see much good politicians involved in it. And sometimes it is important that um, in health sector, non those who are not working with directly health, like medical doctors, nurses, and so forth, general people should be involved from the patient's part also. And we have some movement we have from the health, trained um, health practitioners, but we saw very poor one, the patients part, from the patient part, who are actually the customers of health services. That part is very poor. So there are many ideas we can discuss actually. Yeah. Thank you.
Thank you, sir. Just being worried about the time limit. I have got one question for Dr. Ahmed, and I guess that's going to be the last question for today. But I would like to encourage our participant to communicate anytime through our email, or in other way we can always pass the questions to our speakers. So, Dr. Sayem, the question was from Mr. Rana, and it says, "What role do you see for community engagement and participation in strengthening the universal health coverage system in Bangladesh?"
Okay, yeah, it relates to the other issue Professor Jahangir was explaining, that is the political pressure from the health service user group that is very low in our settings. That also influence our budget allocation as well, because we don't have patient engagement in many decision. So that's why, so those kind of engagement we need to develop. Currently, almost it is inexistent in our country. So we need to involve more the health service user in the decision making, or we should have a pressure group from that side. If I provide one example, when government allocate their budget or fund, there are many pressure groups. Like we have military spending, we have education spending, and other investment in different sectors from the government. So all those sectors, they talk with the government and the minister to allocate more fund to their sector. But from the health perspective, who talk with them or who raise the voices for allocating more money? So we need to develop this community part for health financing, or create political pressure to invest more in the health, because we see the public spending in the healthcare that is more stagnant. So it is increasing in the absolute number, so it increase in amount of money, but if we see the total budget as share of the total budget, it is even decreasing. So we need to develop this kind of community engagement and also the political pressure groups, so that government invest more in the health. And also this private sector that is growing mass even past few decades. So that's why the share of the utilization of the public sector that is declining in Bangladesh context. And also it even creating more inequality, because Professor Jahangir already showed that private sector that is very unequal, and all the benefits going to the research group of the people. So we don't have more option for the poor people to get the health service they need. So that's why this question is very important, but we don't have a good initiative on this community initiative for putting the health financing in the right way. Thank you.
Um, Thank you, Dr. Ahmed. With these questions and discussions, I think we come to an end to our webinar today. On behalf of Health Economics Research Network, I'm thankful to Professor Khan and Dr. Ahmed for sharing your research ideas and findings, and also achieve what are the challenges and what are the opportunities that we can grasp. I believe on the front of capacity building that these research findings and the ideas will enlighten our young minds who have joined today, and we will have more and more interested people will be coming and doing these universal health coverage researches throughout the country, and also on the people who have joined from the other sides of the world. We have Simon with us today. Simon, do you have something to add with me?
No, I think in a matter of time, given the time, just to say thank you everyone for attending, and thank you Professor Khan and Dr. Ahmed for really enlightening and interesting talk and discussion. And we really appreciate your contribution to the Health Economics Research Network.
Yes, sir. Please, if you have something to add at the end.
Yeah, thank you very much. It's a great opportunity for us so that we could reach so many people who are interested in health system, and we hope to work more together for developing the health system of Bangladesh and globally. Thanks, Salman, thanks, Abdullah, and the organizations who are involved here. Thank you.
Yeah, thank you. Anything, Sam Bhai, from your side?
Yeah, I want to thanks everyone also for joining our session. We have many information, but we able to deliver some. But please go through our published article as well if you have more interest. Yeah, thanks everyone.
Thank you so much. Thanks to both of you. Wishing you good health, and thanks to our participants as well for joining today. So as you know that this is a regular webinar series, so we will have some more webinar coming in the upcoming months, and also we regularly uploads the video recording of our webinars in our website. So we will request everyone to access the websites for the information. Thank you so much for joining. Wishing you all good health and have a good day. Thank you so much.